Alhamdulillah, salatu wassalam ala Rasulillah. In this lecture, we'll talk about benign and malignant breast diseases. Before we start talking about the benign and malignant breast diseases, let us start talking about the breast. Actually, the glandular tissue comprises 15 to 20 segments that radially converge at the nipple in 10 central collecting ducts. Each segment is a loop, and each loop consists of small lobules, and they are 20 to 40 per segment. If we take one lobule from here, we can see now that each lobule consists of multiple alveoli or acini. We call it acini once it is filled with milk, and we call it alveoli once it is not filled with milk. So if we take a look here, we have this acinus and the terminal duct. So the terminal duct lobular unit consists of the terminal duct and multiple acini surrounding it. The terminal ducture drains into a larger ducture until it reaches the segmental duct. The segmental duct is around 2 millimeters in diameter and empties into lactiferous sinus. The lactiferous sinus is around 8 millimeters in diameter and empties into the collecting duct to come out through the nipple during lactation. Further details: if we take one acini under the microscope, we will find that the acini consists of 2 layers of cells and stromal tissue surrounding it, which is the intralobular stroma. The epithelial cells are the luminal epithelial cells, which is responsible about formation of milk, and myoepithelial cells, which is responsible about the squeezing of the lobule to secrete the milk into the terminal duct. The patients who will present to the clinic with the breast diseases, they can present either with abnormalities on the screening mammogram, or they have breast or axillary mass, nipple discharge, mastalgia, skin changes, contour changes, nipple changes, or metastatic symptoms. The signs of breast diseases: either lump in the breast or axilla, breast inflammation, like inflammatory breast cancer in this case, or abscess formation, blue orange, due to edema of the breast, and this beating is due to the presence of the sweat glands and the edema surrounding it. Also, the patient can present to you with nipple discharge or a retracted nipple, like here. The retracted nipple here is circumarular retraction, which indicate malignancy, while slit-like retraction, like this retraction, it indicates benign disease like inflammation. The patient also, you can find with them nipple changes, like in breast disease. So it will start as scaly dermatitis, which will end up with destruction of nipple areola complex. Evaluation of the breast. Anybody with breast symptoms comes to you in the clinic, you have to evaluate them according to triple assessment, which is clinical, radiological, and histopathological evaluation. The clinical, you have to go through history and physical examination, and you have to assess the risk factor for malignancy. Radiologically, mammogram for any patient more than 35 years old and ultrasound for every patient, whatever her age. The ultrasound should be used even after the mammogram with every patient as a complementary investigation to complete the investigation. The MRI is not a routine investigation. We are using it just for patients who they have risk factors and they are very young to be screened by the mammogram. Histopathological evaluation will be done by the core needle biopsy, and it can be done through the ultrasound guided biopsy if the mass or the lesion can be seen by the ultrasound. If the mass or the lesion like microcalcification cannot be seen by the ultrasound, you can do for them stereotactic biopsy. And if not, MRI guided if the lesion can be seen only by the MRI. The easiest way to do core needle biopsy is ultrasound guided. Of course, you can do also bedside core needle biopsy in big masses, but preferably ultrasound guided biopsy will give you more information and it will let you direct the needle to the area of interest. Risk factor for the breast cancer. Non-modifiable risk factors like gender and age, personal cancer history, family history of cancer and genetic makeup of the patient, early menstruation and late menopause, breast density and breast conditions, the previous past history of breast biopsies. Modifiable risk factors like body weight, physical activity, alcohol use, smoking, exposure to hormone like taking contraceptive pill or in vitro fertilization and hormonal replacement therapy. Pregnancy and breastfeeding also it's considered as a protective because it will make the breast tissue exposed to progesterone early during the reproductive life. So if the patient get the first child while she is younger than 30-year-old, it will be protective. And also the radiation exposure will increase the risk of malignancy. The classification of breast diseases, actually there are a lot of classifications of breast diseases, but here we'll go through the malignant breast diseases, benign breast diseases, and the benign breast diseases can be classified according to either aberration of normal development and involution and which we will not talk about it here, or non-proliferative, proliferative without atavia, proliferative with atavia. And this type of classification, actually, it is pathological classification, and it is dependent on the how many layers. For example, the diseases where there is only one layer of epithelial cells, this is normal. Once there are two layers or more, we call it proliferative without atavia. Once there is malignant changes of these layer of extra layer of cells, we call it proliferative with atavia. So you will find that in the next slides, we will use such classification while we are talking about each disease. So for non-proliferative are patients who they don't have any increase in the number of the luminal epithelial cells of the duct or the acinine. At the same time, proliferative without atavia, there are two layers of cells, and proliferative with atavia having two layers, and they have atypical changes, which is malignant changes, and we'll talk about this later on. while we are talking about hyperplasia. In this particular lecture, we use different type of classification, which is easier for us, and it will go through the anatomical makeup of the breast glandular tissues. So we have diseases which affect the terminal ductal unit, the diseases which will affect the intralobular stroma, diseases which will affect the lymph ducts, and diseases which will affect the interlobular stroma. We'll start with the terminal ductal unit, and we'll start with cyst. It is an unproliferative benign breast disease. The pathophysiology is not well understood, but we'll talk about it. Simple cyst is a cyst without any abnormality inside it, except simply there are some fluids, and can be complicated like septate cyst, as we see here, or internal mass inside the cyst. The pathophysiology can be explained according to pathologists that high estrogen level causes proliferation of the connective tissues, thickening of the epithelium, and premature involution of the developing terminal ductal unit. The previous process causes fibrosis and disappearance of the surrounding stroma and the breaking down of the small ductules. The breaking down of the small ductules results in an aberrant epithelial-lined fold that walled off the epithelium secretion, which accumulates and forms a cyst. Clinically, patients usually young to middle age, they will present you with lumpy breast, nipple discharge, because some of these cysts will rupture and the fluid will come out, and rarely these cysts will change during the menstruation. On physical examination, we will find tense lump, transilluminated, tender with no signs of inflammation. The diagnosis can be clinically ultrasound and mammogram, and you can diagnose it also after that by aspiration under ultrasound guidance. The treatment of patients with simple cyst is aspiration under ultrasound guidance, complicated cyst or biopsy, and treat according to the result. And if it twice recur or there is a bloody aspiration, then excision is indicated. The second disease which we will talk about is sclerosing adenosis, and it is from its name. The sclerosing means fibrosis or hard tissues, and adenosis, it means increasing in number of glands. So here the gland, we have it here, is the acini of the breast, which is in the terminal ductal unit, but with preserving the number of and shapes of cell, so it will be proliferative without atavia. Clinically, the patient will be middle-aged, multigravida. On physical examination, you will find that the patient having lumpy, painful breast with nipple discharges. Because of a lot of glands, there are a lot of secretions, so these secretions will appear on the duct. The patient can be diagnosed by mammogram, and mammogram can show microcalcifications which can mimic the malignancy. Risk of malignancy in such lesions is controversial. In some studies, reaches 1.5 to 2 relative risk without if the lesion without atavia. The diagnosis can be done by triple assessment, core needle biopsy. If the diagnosis is correlated with the clinical and radiological features, then the excision is not mandatory. So you can just follow the patient and she will not be a high-risk patient according to most of the study. If we look at this slide, which is under the microscope, we can see that there are a lot of adenosis, there are a lot of formation of new glands. And this is from the name of the disease, the sclerosing. There is some also, you will find it very hard, and it will mimic cancer even in the physical examination, and because of the fibrosis. There is a system for sclerosing adenosis, which is the radial scar. It is the same like sclerosing adenosis, in addition that there is atavia, and there are a lot of fibroblastic changes here, which will end up with elastosis. So it will give you stellate lesion because of pulling of tissues around the area of the adenosis. Usually, it is not found as sclerosing adenosis. Why is that? Because it is very small, and usually it is less than 1 centimeter. The evolution of such disease is ill understood, and it can be diagnosed by triple assessment, core needle biopsy, and excision is mandatory as it is highly associated with cancer because there are proliferation and there is atavia. So you will find that any disease which associate with atavia, this is a high risk for malignancy, and excision is mandatory in all types of diseases which contain atypical cells. The third disease which we will talk about is small duct papilloma, or we can call it papillomatosis. It's a proliferative disease with atavia also. It is villus-like or arborescent structure consisting of fibrous core covered by myoepithelial and epithelial cells. So if you concentrate here, you will find that there are multiple small villus-like structure or papilloma. It will be inside the terminal duct tubular unit. So it will be small, and it will differ from the solitary ductal papilloma or single ductal papilloma, which will present retroareolary, and we will talk about it in other slides while we are talking about ducts problem. Clinically, the patient with papillomatosis, they are middle-aged patient, asymptomatic, and you will find it as incidental finding on the core needle biopsy or mammography because it will present with calcification. It will differentiate from the solitary papilloma by the multiplicity and the position, as we mentioned before. The treatment for such condition associates with atavia or malignancy, so excision is mandatory. So it's considered as a risk factor and precursor for breast cancer, but fortunately it is a rare disease. Hyperplasia, as we mentioned before, we have two layers of cells, and we have the basement membrane in the normal breast tissue. But in the hyperplasia, if it is mild, you will have more than two layers, but less than four layers. If it is more than four layers, we call it usual ductal hyperplasia. And usually it is incidental finding with biopsies. The relative risk, because it is without atavia, it is surrounding 1.1 of normal population. The hyperplasia with atavia, once we have more than two layers, myoepithelium and luminal epithelial cells, and the extra layers have malignant features, then we call it atavia. It can be ductal, it can be lobular, and ductal and lobular, it doesn't mean that it arises from the duct. It can arise also from the acini. The name of the disease is it related to the pathological features of the cells rather than the anatomical origin of the tumor or of the hyperplasia itself. Atypical ductal hyperplasia, a pre-malignant condition detected by mammogram as calcification or as incidental findings in biopsy for other abnormality. Usually we treat them with excision, and it should be with clear margin at least 1 centimeter. Atypical lobular hyperplasia is not like the atypical ductal hyperplasia. Considered as a risk factor for malignancy rather than a real disease, usually detected incidentally, treated with follow-up of the patient as high risk. Both breasts in both conditions are at risk of malignancy. The subsequent type is mainly ductal in both breasts. The last and not the least disease in the ductolobular unit is carcinoma. Generally, the classification of breast cancer can be invasive or non-invasive. In both invasive and non-invasive, lobular and ductal, there are another type of classification, and we'll talk about them. Like, if we look at breast cancer and we want to classify it according to the cause, we can classify it as sporadic and hereditary. According to invasion, invasive and non-invasive. According to morphology, not otherwise specified, which is NOS, and it is invasive ductal carcinoma. A specific type like lobular, medullary, mucinous, papillary, tubular, or according to the molecular features like luminal type A, luminal type B, basal or basoluminal. The lobular carcinoma in situ. Once we have that atypical cells filling more than 80% of the lumen of the duct or acini, we call it carcinoma in situ. LCIS, lobular carcinoma in situ, same as atypical lobular hyperplasia. It's considered as a risk factor. Usually we find it as incidental finding on biopsy for other abnormalities. We can treat patient with lobular carcinoma in situ by one of the following options. Follow-up every 6 months and self-assessment every month, or chemoprevention by tamoxifen, or prophylactic mastectomies. And these options should be explained to the patient, and the patient can pick the suitable option of treatment, because most of them, they are BRCA positive and they have very high risk of breast cancer. Ductal carcinoma in situ also, it has the same as we said, the 80% and more of the acini of the acinus or the duct filled with atypical cells and can present with microcalcification in screening programs, countries, blood enabled discharge, and it's considered as the second common cause of blood enabled discharge after solitary ductal papilloma, or in non-screening program areas can present as a lump. The treatment, if it is localized disease, then we'll do for them lumpectomy with 1 centimeter free margin. If it is diffuse micropulsification will do for them mastectomy. This is the treatment options for DCIS. It is a precursor for development of invasive ductal carcinoma. Once the atypical cells or malignant cells cross the basement membrane of the acinus or the duct, we call it invasive cancer. The general approach of patients who diagnosed with invasive cancer is staging after diagnosis and then management, because all management of malignancy depend on the staging. The staging will go through the TNM staging. We have here TX. The primary tumor cannot be assessed. That means the patients had already excisional biopsy of the tumor, which is not recommended now in another hospital, and in the patients come to you. You cannot assess how much has been taken in the previous surgery and how much left. T0, no evidence of malignancy. TIS, in situ tumor, DCIS, and budget disease. T1, the primary tumor is less than or equal to 2 centimeters. The T2, more than 2 centimeters but less than 5 centimeters. The T3, the primary tumor is more than 5 centimeters in the largest dimension. Once the tumor attaches to the skin of chest wall, we call it T4, whatever the size. If it invades the chest wall, serratus anterior ribs, or intercostal muscles, T4A. And you can note that we didn't mention anything about the pectoralis. So if the pectoralis is invaded, we don't say that this is T4. T4B, presence of tumor foci in the skin, like stellate nodule or ulceration. T4C, tumor invade the muscles mentioned above and the skin both together. Inflammatory breast cancer, we state it as T4D. For the lymph node, N1, movable ipsilateral axillary lymph node with metastasis. N2 is fixed ipsilateral axillary lymph node with metastasis or isolated internal mammary lymph nodes. N3, involvement of internal mammary lymph node plus ipsilateral axillary lymph node or metastasis to supraclavicular lymph nodes. The metastasis, M0, no metastasis, and M1 if there is any metastasis. The staging maybe looks a little bit complicated, but it's very, very simple. Any tumor less than T3, we call it early breast cancer. At the same time, it has a lymph node less than N1. So, if there are more than T3 and N1 and more with T3, we call it locally advanced breast cancer. If there is metastasis, then we call it metastatic disease or stage 4. What we have to know that there are early breast cancer, locally advanced breast cancer, metastasis, and these are stages of breast cancer, either early breast cancer, local advanced breast cancer, and or metastasis. And the treatment plan will depend on these stages. How can we stage the patient? First, clinically, of course, but we have to look for metastasis radiologically, like CT scan, CT chest, abdomen, and pelvis, bone scan for bone metastasis, routine investigations like CBC, LFT, and renal function test, calcium and alkaline phosphatase, tumor markers as a baseline for follow-up of the patients, like carcinoembryonic antigen or cancer antigen CA15-3. The infiltrative ductal carcinoma or invasive ductal carcinoma of NOS, none otherwise specified. It represents 80% of breast cancer and affect 40 years old ladies and more. Presents as a stony hard lump, and the most common area is upper outer quadrant because there are a lot of fibroglandular tissue distributed there. So the upper outer quadrant is the most common area of cancer. Invasive lobular carcinoma represent 55% of breast cancers, arise in acinar cells and terminal ducts also, can be multicentric, silent growth, late can present with a mass. The treatment, of course, depends on the staging. For early breast cancer, we do for them surgery first, then they will go for adjuvant chemotherapy and the radiation. And surgery, either they can go for breast conserving surgery, like lumpectomy and axillary dissection or sentinel lymph node biopsy. If there is contraindication for breast conservative surgery, then we can go for mastectomy and axillary dissection. And this is, we call it modified radical mastectomy. Sometimes the patient doesn't have positive lymph node while they have indication for mastectomy or contraindication for breast conserving surgery, then we can do for them axillary assessment by sentinel lymph node biopsy. If the patient has hormonal receptor positive, then the patient can go for hormonal therapy. If the patient has HER2 positive, the patient can go for biological therapy. What are contraindications of breast conserving surgery or conservative surgery? Previous history of radiation to the chest or breast. The tumor is more than 20% of the breast volume. Radiation required during pregnancy. Diffuse malignant appearing microcalcification. Inability to achieve a negative margin due to widespread disease. All contraindications for breast conservative surgery are contraindication of radiation. Why? Because the radiation is a mandatory step after breast conserving surgery because it will decrease the recurrence rate in such patient to the level of mastectomy. In locally advanced breast cancer, we'll start them on neoadjuvant chemotherapy, then surgery, and then the patient can go for radiation. The surgery, it is not less than mastectomy and axillary dissection. Metastatic breast cancer, we can take them for palliative chemotherapy. We'll start talking about large duct diseases like ductictasia. The mammary ductictasia is dilatation of the lactiferous duct or sinus. The exact etiology is unknown, is a non-proliferative benign condition of the lactiferous duct, although the mammary ductictasia was reported in children. It is considered an involutional process of breast tissue. Clinically, the affected woman, either in late premenopause and or in early postmenopause reproductive life, usually they present with unilateral nipple discharges, green, brown, or yellow, redness and hotness of the nipple areolar complex if there is infection, oval tender subareolar mass, new onset slit like retraction. Some patients are asymptomatic. Diagnosis: triple assessment to rule out malignancy, and then you will find that there is a dilatation of the large duct. The treatment of such patient: treat the superimposed infection of the stagnant secretions. The most common bacteria are Staphylococcus aureus. We have to rule out malignancy, as we mentioned before, and excision of the dilated duct must be done. Recurrent subareolar abscess, periductal mastitis. It is inflammation of the large mammary ducts of unknown etiology, strongly associated with tobacco use. 5% of women are at risk of periductal mastitis. Diabetes and obesity are risk factors. Clinically, smoker, diabetic, obese, and middle-aged lady. The patient will present with subareolar mass with signs of acute infection, erythema, redness, and hotness, subareolar abscess formation. Sometimes the patient will have signs of chronic infection like fistula and fibrosis of the underlying duct, can cause also nipple retraction. Again, diagnosis by triple assessment. Ultrasound will show you the abscess, and then the mammogram after control of inflammation. It can be complicated by fistula, and recurrence is very high. Treatment: control the predisposing factors like smoking. Start the patient on antibiotics. You can aspirate the abscess and send it also for culture. Excision should be preserved for patients who they have recurrence or fistula formation. Lactational mastitis is an infection of inadequately drained milk by bacteria that entered through a cracked nipple. Lactational mastitis affects up to 30% of breastfeeding women. The incidence is higher during the first 3 weeks of postpartum. The most common isolated bacteria are Staphylococcus aureus. Other types of bacteria were also isolated, like Escherichia coli. Clinically, the patient will present with painful breast engorgement, and she's lactating, localized mass with symptoms and signs of acute infection. Diagnosis by clinical evaluation, of course, and ultrasound to rule out abscess, because if there is an abscess, you have to aspirate the fluid of the abscess and you send it for culture and sensitivity. And also, we are using aspiration as the first line of management of any lactational mastitis. Treatment: encourage the drainage of inadequately drained milk by feeding or using a milk pump. Nipple care: skin moisture on the nipple. Cold baths decrease the inflammation, and hot baths increase milk drainage. Antibiotic against common bacteria like amoxicillin or ciprofloxacin. Aspiration of the abscess under ultrasound guidance is the first choice of management, and the surgery will be reserved for intractable cases or if the patient is septic and cannot control the sepsis except by incision and drainage of the abscess. Solitary ductal papilloma or solitary intraductal papilloma is growth of true polyp that is lined with epithelial cells and has a stalk, like what we can see here. Blood supply runs through the stalk. The friable epithelial layer can slough and result in bleeding, like in this case. Clinically, the most affected women are between 33 and 55-year-old. Nipple discharges are variable in amount and usually bloody, and it is the most common cause of bloody nipple discharge is the solitary ductal papilloma. Retroareolar mass, variable in size, it can reach 5 centimeters. Diagnosis: clinical evaluation, mammogram. You will find retroareolar mass with benign features and dilated duct with pedunculated mass. Whole needle biopsy can be used for diagnosis, and treatment is surgical excision to rule out presence of atavia and DCIS. Paget disease of the breast is uncommon presentation of underlying malignant breast lesions. The most common type of underlying malignancy is DCIS. The adenocarcinoma cells travel from the underlying ducts to the nipple, and it goes from here. This is the DCIS. Usually it is 2 centimeters away from the nipple, and it will go through the cells will go through the large ducts, and it will invade the nipple areola complex. Clinically, same age distribution as DCIS and the basic ductal carcinoma. They all are older lady. Usually will start with scaly dermatitis like this patient, and then it will end up with destruction of the nipple. Sometimes will have bloody nipple discharge, ulceration of the nipple, destruction of the nipple, as we mentioned before, and less commonly is associated with underlying mass. The presence of underlying mass indicates invasive cancer in most of cases, rather than ductal carcinoma in situ. Diagnosis: the patient can be diagnosed by clinical evaluation, mammogram, and ultrasound to rule out an underlying mass. Bunch biopsy, because it will show us the presence of adenocarcinoma in the epidermis, and the bunch biopsy has a specific type of knife that it will go down through the skin and it will take some underlying tissues, so you can diagnose the Paget disease of the nipple. Usually the treatment is mastectomy and axillary evaluation. If underlying malignancy is invasive cancer, then treat the patient according to the stage of the cancer. The intralobular stromal disease, we'll start talking about fibroadenoma, which is very common condition, especially in young lady. It is a non-proliferative fibroepithelial tumor of the stroma that surrounds the terminal ductal unit, and it is the disease of intralobular stroma, as we said. Clinically, the patient usually young, from 15 to 25. If the fibroadenoma appear in adolescents or children, we call it juvenile fibroadenoma. And if it is more than 3 centimeters, we call it giant fibroadenoma. Usually the patient will have multiple or single mass, not tender, except in few cases. Firm in consistency, well circumscribed, not fixed, and variable in size. Increases in size during menstruation because the epithelial cells have receptors for estrogen and progesterone, and this is will increase the size. The diagnosis of fibroadenoma will start by clinical evaluation and ultrasound. It will show you the benign lump. Mammogram if the patient more than 40, and you will go for core needle biopsy to make sure about the diagnosis. The treatment, yearly follow-up if it is less than 3 centimeters and the patient is young. If it is more than 35, if the patient is more than 35 or the tumor is more than 3 centimeters, this is indication for excision. This is how we can see it under the microscope. As you see here, there are fibroepithelial proliferation. Phyllodes tumor, it is a non-proliferative fibroepithelial tumor of the stroma that surrounds the terminal ductal unit. Phyllodes and fibroadenoma differ as the phyllodes have a dominant stromal fibro growth over glandular part. Depending on the biological activity of the tumor, is classified as benign, borderline, or malignant disease. Clinically, the patient will be older than those patients who present with fibroadenoma, and they will have well circumscribed, firm, non-fixed, and non-tender mass more than 3 centimeters. It doesn't increase in size during menstruation because most of the tumor is a stromal tumor, which it doesn't have estrogen and progesterone receptors. We can diagnose them clinically, and ultrasound will show you benign, large lobulated lump associated with necrosis and cyst formation sometimes, because it will have necrosis and then cystic formation or liquefaction. Mammogram will show benign lump, and core needle biopsy for definitive diagnosis under the microscope. The treatment, benign phyllodes are treated with excision with free margin 1 centimeter. Borderline or malignant are treated with excision with 1 centimeter free margin in addition to chemoradiation therapy according to protocol of sarcoma. Recurrence is very high even in benign. That's all, and thank you very much.